I didn't understand how was the organization of this presentation today, but we are free, and so we can try to invent something to do a good webinar. So
can we start?
Yeah.
I mean, I think.
How many have joined? You can see.
I can see 35. I mean, by the time 10 minutes into the presentation, I think more will be there.
Mm-hmm.
We have a cutoff of 100, beyond which it will go to the YouTube link.
Oh, okay. But do the delegates know that? Or
Yeah,
if they're trying the Zoom?
Yes,
it
they
will
have.
automatically go to the YouTube.
No, they have that option. They can go directly to YouTube. I think we can start, I guess. I mean,
great.
Abhi, you want to start?
Yeah, okay. Shall I start?
Yes.
A very good evening to everybody. So today's session is going to be an exciting one. I first of all thank the Ankura Hospitals for organizing such a wonderful session. Today's session is on comparing the neonatal resuscitation guidelines given by various councils like ILCOR, ERC, and American Heart Association. So for that, this will be, the session will be done as a short presentation by Dr. Veera Raghavan, and it will be followed by a panel discussion by two experts from AHA and ERC. So we have with us Dr. Gary M. Weiner. He is the editor-in-chief of the 7th and 8th editions of the AAP textbook of neonatal resuscitation. He is also a co-chair of the NRP's Instructor Development Task Force, and he is a member of ILCOR Neonatal Life Support Task Force. He is part of AHA Resuscitation Guidelines Writing Committee, and he is affiliated to the University of Michigan in USA. We have also Dr. Daniel Trevisano too. He is the secretary of the study group of neonatal resuscitation from Italian Society of Neonatology. He is also a member of ILCOR, Neonatal Life Support Task Force, and he is an important member of ERC, that is European Resuscitation Council. He is affiliated to the University of Padua. So they both will be doing the panel discussion. I first invite Dr. Gary and Dr. Daniel to say a few words.
Good afternoon, evening in the United States. Good morning, everybody. Thank you so much for inviting me, Dr. Abby, Dr. Veera. It's really a pleasure to get to meet with you all and your delegates to talk about the how the guidelines from ILCOR, ERC, and American Heart Association are developed and where there may be some differences. And I'm looking forward to the opportunity to answer questions from all of your delegates.
Hello to everybody, and thank you, Dr. Abby, thank you, Dr. Veera, for inviting me. I am very happy to discuss with Gary Weiner the differences between American and European guidelines, and we hope to have your question and to be able to answer, because we hope your question will be not too much difficult, because there are some questions that are easy and or how to say, there is evidence for some question that is strong, and so we can try to give you a reasonable answer. But some things that we do in the delivery room still need more evidence, and so we will see why we decide in the different committees, starting from the same basic document to develop, to recommend. And so thank you again for inviting me.
I'm glad to introduce Dr. Veera Raghavan. He is a consultant neonatologist from Ankura Hospital for Women and Children at Hyderabad. Fortunately, we were working on a manuscript with Dr. Gary and Dr. Daniele, comparing the guidelines given by ILCOR with that of the guidelines given by ERC and AHA. So that manuscript is the basis for today's session. And Dr. Veera Raghavan was the major brain behind this. So he'll be starting with the introduction slides. Over to you, Dr. Veer.
Thank you, Abhi, Professor Gary, and Professor Daniel. So this is a brief overview of the today's session. The first part, we will look at the differences between ILCOR, COSTAR, AHA, and ERC guidelines. Then we'll move on to the discussion, which will be done by Gary and Daniel on the basis for the varying recommendation between the different councils. And finally, we can take some questions from the audience as well. I'm sure the audience would be more interested in listening going into the second section. So I will try to finish the first one as early as possible. So as many of you might be aware, ILCOR COSTAR forms the framework for other resuscitation council recommendations. The members of different regional councils, including that of AHA and ERC, they are all part of the Neonatal Task Force of ILCOR. So some recommendations might vary between these regional councils, but predominantly their foundations, their framework is based on COSTAR. So if you look at the differences between AHA 2020 and the European Council 2021 guidelines, it's quite obvious that they differ at many points, starting right from the way the guideline is developed, to the way the document is presented, to the various steps involved in the resuscitation of neonates, including the use of drugs in the delivery room, the guidance on communication with parents, and finally the algorithms put forth by the regional councils. Coming to the guideline development process and the document structure, ILCOR utilizes the grade working group recommendations, whereby they divide the levels of evidence into 4 and they give 2 strengths of recommendations. Either it is a strong recommendation or a weak recommendation. AHA utilized its standard methodology and terminologies for classifying the level of evidences as well as the strengths of recommendations. So they classify into 5 levels and 5 strengths. These are beautifully depicted in their document, which in a color-coded format. The European Resuscitation Council, most of their guidelines are taken from ILCOR COSTAR and which had utilized the grade process. They have dwelled upon 2 aspects of resuscitation that were not addressed in the ILCOR documents. So for those areas where they have given newer recommendations, they have not spelled out the level of evidence or the strength of recommendations. But if you look at the document structure, the ERC document is a standalone comprehensive document where you will get all aspects of newborn resuscitation in one single in one single go. It's more easier for a reader to go through the European resuscitation guidelines. When you compare that with COSTAR and AHA guidelines, they don't retire their previous recommendations, so they might not have addressed in the current version. So if the reader wants to look at what the AHA says about a particular topic, he might have to go back and forth between different versions. So compared to AHA and ILCOR, ERC is a standalone comprehensive document, easier for the readers to interpret. Now coming to the steps of resuscitation, only the European Council stratifies newborns into 3 categories based on their heart rate, respiratory efforts, and tone. So these 3 categories include satisfactory transition, incomplete transition, or a failed transition. The further steps on resuscitation are all guided by the category into which the newborn is classified into. So they have illustrated this using diagrams. So if you see a newborn who has a good heart rate of more than 100 with good respiratory efforts and a good tone, it will be classified as being into the satisfactory transition criteria. If a newborn who has a heart rate of less than 100, who is fully floppy and who has got no breathing efforts, would be classified as having a failed or a poor transition. Now coming to the topic of thermal adjuncts in very preterm newborns to maintain normothermia in the delivery room, the ILCOR and the AHA recommendations are almost similar. They advise for a combination of strategies, including maintaining the delivery room temperature at 23 to 25 degrees Celsius, use of radiant warmers, plastic bags, thermal mattresses, and warm humidified gases. The strengths of recommendations vary between ILCOR and AHA. However, the overall gist of it remains the same. Where European Council differs from these two is in the aspect of delivery room temperature. The European Resuscitation Council advises for a delivery room temperature of more than 25 degrees Celsius for anticipated births of gestational age of less than 28 weeks. So that is one part where they differ. And the other aspect is related to skin care. The European Council is more objective. They say that beyond a gestation of more than 32 weeks, and if the newborn is stable, you can go for skin to skin care. Though AHA also stresses on skin to skin care for healthy neonates, they don't give an objective category or criteria beyond which it is safe. Now, coming to delayed cord clamping and umbilical cord milking, similar to the previous aspects, ILCOR and AHA were almost similar in their recommendations. While AHA advised for a delay of at least 30 seconds, ILCOR went for a delay of at least 1 minute before the cord is clamped. This is in babies who are otherwise normal, who are crying at birth and are not asphyxiated. Both of them recommend against umbilical cord milking in babies who are at a gestation of less than 28 to 29 weeks. ERC differs a bit. They give the option of doing delayed cord clamping in neonates who are categorized as having an incomplete transition. That is when the heart rate is between 60 to 100, when they have inadequate breathing efforts and their tone is not well. So in such newborns, the European Council states that you can do delayed cord clamping till the first breaths are established if the provider can support the newborn at the mother's bedside and maintain the temperature. So this is something that is quite different from ILCOR and AHA, where they are very clear. If the baby does not cry, take the baby to the warmer. Whereas ERC just give that option of doing delayed cord clamping in babies who who are categorized as having an incomplete transition. And they also state that you can do umbilical cord milking if DCC is not feasible. Now, coming to this important aspect of heart rate assessment, as you all know that newborn resuscitation is almost always guided by the response of heart rate to whatever steps you do. ILCOR and AHA suggest the use of ECG for heart rate detection. AHA goes a step ahead further and strongly recommends using ECG during chest compression for continuous heart rate assessment. ERC's recommendations were quite diagonally opposite. They told you can use a stethoscope, a saturation monitor with or without an ECG. Now, coming to this debated topic of sustained inflations, both ILCOR and AHA say no for sustained inflations. But what we have to see is how they define the sustained inflations. ILCOR says it recommends against sustained inflations with an inspiratory time of more than 5 seconds. The American Heart Association strongly recommends against sustained inflations of more than 10 seconds. The European Resuscitation Council, traditionally Europe in many countries, they do sustained inflations. They recommend for 5 initial inflations of inspiratory times of 2 to 3 seconds duration. So if you see it carefully, they don't conflict. None of these recommendations conflict, only that they define inflations differently. Now, coming to the rate and initial peak inflation pressures for positive pressure ventilation, the ILCOR says to use a rate of 30 to 60 per minute. We had to search a lot to get this recommendation because this was given in 2005 and they have continued it like that since then. The PIP for the initial positive pressure ventilation, ILCOR says for preterms, use a pressure for range of 20 to 25 centimeters of water, and for terms around 30 centimeters. The AHS recommendation is much more simpler. They go for a rate of 40 to 60, which is within the range suggested by ILCOR. But the pressures, they have recommended to use a pressure of 20 to 25 centimeters for both preterm and term. AHS does acknowledge that many term babies might require a bit higher pressure. The European Council recommendations are quite different and they are very objective in their recommendations. They say that in preterms, instead of 20, you have to use 25 centimeter as the initial PIP. And they say if you use a pressure of 20 in preterms as the initial breaths, it might be insufficient. And similar to ILCOR, they advise for a pressure of 30 centimeters for term babies. And the respiratory rate, so the rate of the positive pressure ventilation, ERC says anything about 30 per minute is adequate, which is also in the range of what ILCOR had suggested 16 years back. Now coming to 2% technique for PPV in India, we usually follow the NRP textbook. Gary is the main editor. So we are not aware of this 2% technique, but in Europe, they are big fans of 2% technique for PPV. It is a ventilation correctory step. That is, if you are getting inadequate chest rise with your positive pressure ventilation, you can take the help of a second person who will hold the mask and give an anterior jaw thrust. And the first person can continue with the positive pressure ventilation. So it is something like this. The second person holds the mask firmly against the chin and nose, and the first person gives the uses the TP's resuscitation. Coming to this often debated topic of oxygen concentration for initial preterm resuscitation, ILCOR and AHA, they are quite similar in their recommendations. They say use an FiO2 in the range of 21 to 30% for those preterm babies who are born at less than 35 weeks gestation. The European Resuscitation Council recommendations are more objective. They say go for an FiO2 of 30% for babies who are born at less than 28 weeks, 21 to 30% for babies who are born at 28 to 31 weeks, and 21%, that is room air, for babies who are born at 32 weeks or more. These are very similar, or as they have suggested in the European RDS consensus document in 2019. Now coming to the use of drugs in the delivery room, the European recommendations are a bit deviant from ILCOR and AHA. The European recommendation suggests to use naloxone in certain situations when the mother has received opioids in labor. They also suggest the use of sodium bicarbonate as a prophylactic measure in prolonged resuscitation and when the ventilation has been adequately established. They also suggest for the use of intravenous or intraosseous glucose after prolonged resuscitation. The AHA and ILCOR recommendations are almost similar. For example, AHA says monitor the blood sugars and then tailor the treatment, whereas ILCOR says start glucose infusion as early as possible. Communication with parents is something that the European Council really stresses on. So they have given a detailed guidance on communication with the parents before, during, and after resuscitation. They also support the familial presence during the process of resuscitation, which is quite a norm in Europe. Planned home deliveries do happen in Europe. So you have a detailed guidance on what all things needs to be done for planned home deliveries in European Council guidelines, but this is not addressed in ILCOR or in American Heart Association's documents. Now, finally, coming to the algorithms, there were significant differences between the three algorithms of ILCOR, AHA, and ERC. The AHA algorithm was almost similar to that of ILCOR. It was a bit sparser and based on technical norms. The ERC one was a bit denser with inclusion of multiple checklists, reminders, and arrows, and so on. So if you just eyeball the algorithms, you can perceive that the ILCOR and AHA have a very similar pattern. The shapes of the boxes might vary a bit, but the color coding is almost the same. And the ERC one is more denser and it is packed to the core. So this is a topic on its own. If you go deeper into the algorithms and stuff, we might not be able to finish our presentation. Just to be short, they differed quite significantly. Now, this AGREE2 is a tool that we use to assess the quality of different clinical practice guidelines. And this has got several domains. Usually 2 to 3 independent reviewers assess the quality and then they score the agreement between them. So Abhi and myself have independently assessed the quality of these 3 guidelines. Our overall impression was that all the 3 guidelines were good to use with some modifications. If you look at the individual domains, the AHA describes the scope and purpose of the guidelines better than the other 2. The stakeholder involvement was better in the ERC document. Of course, ILCOR COSTAR, the rigor of development, it scored the highest. and the ERC scored the least. The main reason why the score was quite low for rigor of development for ERC was that the strength of recommendations or the levels of evidence, the search strategy used were not clearly spelled out. So for that particular domain alone, the ERC scored a little lesser. But if you look at the clarity of presentation, ERC is much easier to read, as I pointed out before, and it scored better than AHA or ILCOR. So the final quality, all of them are of good quality. Obviously, I don't have to say it, but they scored almost equally. Now, I finished with the initial part where I just outlined the differences between the different guidelines. I hand it over to Abhi to ask questions to Gary and Daniel. Over to you.
Yeah, thanks, Veer, for such a clear and concise presentation. So we are moving on to the next session, which is the discussion on the basis for the varying recommendations between the different councils. So the first question will be to Gary. So why are there so many differences between the guidelines given by ERC and AHA, especially when both are based on ILCOR COSTAR and the members of both ERC and AHA are actually members of ILCOR developing COSTAR?
Abby, that's a great question, and you're absolutely right. The primary, in fact, I think essentially all of the people that are responsible for writing the ERC guideline and the American Heart Association guideline also sit at the table writing the ILCOR COSTARs and the individual questions on the COSTARs. So some of what you're seeing when there are differences between ERC and American Heart Association guidelines is the organizations that support these guidelines have different rules when it comes to drafting them. So the American Heart Association rules are much more restrictive. And then the document itself, as Dr. V mentioned, isn't meant to be a comprehensive document for how to resuscitate a newborn. In North America, the way it's structured is the American Academy of Pediatrics develops the comprehensive educational materials that put the American Heart Association guidelines into practice. And so you'll see some of the guidelines that are written in the ERC document. For example, as Vera was mentioning, the two-hand hold and communicating with parents, they don't appear in the AHA guidelines, but they're found instead in the educational and implementation materials that are published by AAP NRP. And so the NRP textbook fills in many of the gaps that are not in AHA guidelines. And from the AHA standpoint, it has to do with the purpose of the document. The rules that American Heart has for writing the guidelines documents, they're more restrictive. And then the location where you'll find some of that other material to actually put this into practice will be found in the textbook. One of the things that Dr. V pointed out was that previous to 2015, the American Heart Association document was a comprehensive document, and it would be a convenient place to go and find everything. And in 2015, AHA changed their rules, and so now it is much more of a what questions have been asked and in this last cycle.
Okay, thank you, Gary.
And then if you go on to the next slide that V has for you, I think where you find some of the differences, they're related to the evidence gathering process around practices, largely with little scientific evidence, and others may just reflect different interpretations of how to implement the available evidence when there was low certainty. So many of the differences are where there were scientific questions that had little evidence or low certainty evidence.
Yeah, thank you. As Gary rightly pointed out, wherever there is adequate evidence, there is not much difference. So the major differences between the guidelines are for those aspects that do not have adequate evidence. Thank you, Gary. So we'll move on to the next question. So this is to both Gary and Daniel. So does ILCOR COSTAR apply to low and middle income countries? So do we have adequate low and middle income countries representation in the ILCOR Neonatal Task Force? So why we are asking this question is when COSTAR recommends pulse oximetry, we are still struggling to get a pulse oximeter in our delivery rooms. But now we have gone to the next level of using ECGs. So when COSTAR gives guidelines, I think they should also think of the facilities in low and middle income countries and what we can do to adapt all these recommendations. Gary, could you please start?
Oh, sure. Yeah, so I would say, the ILCOR task force, and in particular, ILCOR is divided into adult, pediatric, neonatal, first aid councils or task forces. And in particular, I think the neonatal task force has really worked to improve its representation. The ILCOR task force members in general represent the 7-member national councils. There is a process for councils to join ILCOR, and right now ERC represents primarily Western Europe, and American Heart and the Canadian Stroke Foundation represents North America. There's ANSCOR representing Australia and New Zealand. There's the Asian Council and a council from South America. But individuals from countries that aren't represented by a member council can become a member of the Content Expert Advisory Group, and they can also apply for ad hoc membership. And so if there are people who are expert in resuscitation in countries that aren't represented on ILCOR, one of the most probably effective methods of getting involved is to join the Content Expert Group. And then the current NLS task force does have, and the expert group has reasonably broad representation, as I said, from Australia, Brazil, Canada, Chile, Japan, Italy, New Zealand, Singapore, South Korea, South Africa, the UK, and the United States. However, the members of NLS Task Force are acutely aware that we don't have as much representation as we would like from resource-limited settings, and that's a topic that's regularly discussed. And there are goals certainly to improve the representation. And every time at ILCOR we discuss a topic, we always, and in the evidence to decision table, we always address how can this be implemented internationally, and is this something that can be implemented internationally?
Yeah, Dr. Daniel, you want to add on?
But in general, Dr. Gary have already said what and in the slide it is written what we intended. What you have to know is that yes, we want the ILCOR group want in general, not only Neonatal Task Force, also the other task forces would like to increase the representation of doctors from low resource setting. And it is very interesting because many times in our task force, for example, Ruth from Brazil tried to underline some statements that are clear or are easy to understand, or to better say are easier to put in practice in high resource setting. But the question is, okay, but you are crazy. Sometimes she said, we are crazy. It is not possible to do such recommendation for Brazil, for example, or if you want for other low resource setting. And so the point of view of these people are very important to the group, or to the preparation of the recommendation, treatment recommendation, and of course for the preparation of the guidelines. And so I think that people from low resource setting are very well expected, and we would like to involve to enlarge this representation, despite the limitation of the ILCOR rules that are also that we have to take in consideration. But I think that in the future, this is the also during the last meeting we discussed this aspect, and so is a hot topic for the group.
And Abby, I think it's important to recognize that ILCOR guidelines, when they're published, are not intended to necessarily be used as guidelines for the individual resuscitation of babies internationally. When the guidelines are written, they're actually meant to speak to resuscitation councils, so that your National Resuscitation Council is intended to use the ILCOR document to figure out how to implement that science effectively in your own setting. Because clearly it's impossible to write a single guideline that can be implemented in every setting across the world. And so ILCOR guidelines are intended to speak to councils, and then individual councils are intended to write guidelines for implementation in their region or nation. And so I think as long as we pay attention to what ILCOR is intended to be doing, it makes it more reasonable when you read it.
Yeah, you're right, Gary. But only thing is like when even in India, we have our own NRP group who formulate our guidelines, but we also follow whatever is given from ILCOR COSTAR. So I think it is time for both of you to go and talk in your this thing ILCOR to get members from LMICs like India and all the other countries, and probably like you have to take into consideration the situation here as well while formulating guidelines.
An opportunity to give a comment to the cost that are published in the ILCOR website is a good opportunity for neonatologists around the world, because the points of view are considered for the ILCOR group, and so that is a good practical and fast and feasible opportunity to enter in the discussion of the cost decision.
And every COSTAR is published or is posted on the ILCOR website and open for public comment, and the task force reads those comments, and they can have an impact on the final, because the draft is what's posted, and the final COSTAR can be impacted by comments from those publicly available section of the website.
Yeah, that is a very important information. Thank you, Gary. So we'll move on to the next question. This is to Daniel. So the initial risk stratification of neonates is given only by the ERC. So what is the evidence behind this? Daniel?
We decide to use the design for risk stratification for educational purposes. And as you can see here, it's very easy to understand. It remember the helping baby breathe algorithm, where you use the design instead of using words. And the important aspect, of course, as Dr. Vera presented before, is heart rate, respiration, and the tone. There is a fourth clinical signs here. If you see the picture, and is the color. Here, when you have the figure for 8, you have a pink baby. Here you have a black, a blue baby or cyanotic baby, and you have pallor. And in the last, when you are in the difficult situation. And I think that for educational purpose or training, I think it's very clear. We discussed a lot of in the group on this figure, because it is very simple, but it was very complicated to decide, and there was a large discussion. For example, on the tone, okay, because American Heart recommend heart rate, respiration, and color, or if you want, saturation is better to say. But we discussed it in the group, is it important, the tone? And for example, some of us, in particular, Colin Morley, was very motivated to stress the aspect of the tone as clinical sign. And so this is the reason why we decide to include this figure along through the presentation, through the guidelines. And so that is why we decide to use it.
And I say American Heart in the algorithm, it's actually very similar. I think we generally agree. American Heart has actually removed color from the assessment because people we feel that color is so difficult to assess in the delivery room. And in American Heart, it's about breathing, crying, and tone. And so that's what appears in the very top of the algorithm. And so I think in general, we definitely agree. And when you look at the NRP implementation of American Heart, I think we completely agree with ERC on the assessment of these questions. And for normal newborns who are with their mother, then we recommend ongoing assessment of color for cyanosis, and if cyanosis is present, to use a pulse oximeter. But This graphic we haven't adopted, and this is a unique one that I think we should talk about. But the content we completely agree on.
Especially this picturesque representation will be easier for other health workers, like in the primary health workers to follow. The doctors may be able to assess even much more better, but this will be very easy for health workers to follow. We will move on to the next question. This is to Gary. So why did AHA give a strong recommendation against using umbilical cord milking in neonates less than 28 weeks of gestation?
So the American Heart Association guideline, the comments on it are based on the manuscript that's demonstrated here. It's from Anup Katharia's paper published in JAMA, and it's data that comes from the PREMOD trial, which was cord milking versus delayed cord clamping, and it was a multi-center randomized controlled trial involving babies from 23 to 31 weeks. And in a post hoc analysis of a prematurely terminated trial, they found, I should say at first, they found the Data Safety Monitoring Committee at the very first interim analysis found a safety signal warning that umbilical cord milking may be dangerous. And the trial was stopped with just about 2/3 of the patients enrolled. So they had actually enrolled approximately 470 patients out of a planned 750 patient study. They found no difference in the primary outcome, which was a composite outcome of death or severe IVH. It was 12% in the cord milking group and 8% in the delayed cord clamping group, which was not statistically significant. But when they looked at individual outcomes instead of the composite, there was an increase in severe IVH in the cord milking group. And at that point, when they looked at the entire population in the study, it was 8% versus 3% with a risk difference of 5%, and it was statistically significant. When they completed as they looked deeper into it in a post hoc analysis, there was an interaction between gestational age and the treatment group, such that if you looked at the smallest babies, those between 23 and 27 weeks gestation, there was a statistically significant and clinically significant difference in severe IVH. In the cord milking group, it was 22%, and in the delayed cord clamping group, it was 6%, resulting in a risk difference of 16%. And so when the American Heart Association guidelines were being drafted, which was the summer and fall of 2019, we were very concerned about the risk of umbilical cord milking in the smallest babies. In addition, there was animal data from Stuart Hooper's research group in Australia that suggested that cord milking led to wide swings in cerebral blood perfusion. And so between the concerning animal data and the post hoc analysis that was just coming out at that time from the PREMOD 2 trial, we were very concerned about the risk to smallest babies.
Yeah, I agree. So that leads us to the next question. So there is a recent systematic review and meta-analysis from ILCOR that suggests that both UCM the risk of severe IVH is the same with both UCM and DCC. So what is your take on this? And after this, will there be any change in the AHA's strength of recommendations?
That's a great question. And of course, we knew as we were writing the American Heart Association guidelines that there were two very complicated systematic reviews underway. These are among the most complicated meta-analyses I've ever read. And it was the umbilical cord management strategies for preterm and near-term and term babies. And so ultimately, Anna Seidler published in pediatrics both of these systematic reviews, which the final publication came out just this year in 2021. If you look at the delayed cord clamping versus versus intact cord milking, because again, there's two different strategies for cord milking, right? There's intact cord milking, which most of the studies used, and cut cord milking. If we focus on intact cord milking, ultimately there were 7 studies that were included in the randomized trial in the meta-analysis, and there was no difference in the outcome survival. And when you look at specifically the severe IVH outcome from all of it, the point estimate favored delayed cord clamping over intact cord milking. But it wasn't statistically significant. It was very close. You know, we always talk about whether if the confidence interval is close, should you, what should you think about it? But certainly the point estimate favored delayed cord clamping over umbilical cord milking. And so they did not find a difference. However, in Seidler's meta-analysis, they could not stratify by gestational age, and we're certainly still concerned that when you look at all babies under 34 weeks in one big category versus being able to stratify by into the smallest group, that this may well be a type 2 error. And in type 2 error, it's the statement that absence of evidence isn't equivalent to not having a difference. And so we're concerned that this may be simply a type 2 error. When you look at at cord milking versus early cord clamping, there was no clear difference in any of the significant outcomes. And so even with the Seidler meta-analysis, given that there is no clear difference, no clear benefit to umbilical cord milking versus early clamping in that gestational age group, and the real still concern about the smallest babies, I don't expect a change from American Heart Association until there's more evidence available. And again, there's a planned individual patient meta-analysis that may help us.
Okay, so you are not for umbilical cord milking?
In the smallest babies, I'm concerned about it. So I think American Heart is very supportive of delayed cord clamping. We're uncertain what to do if babies need immediate resuscitation. And we're very interested in what will come of the mother side resuscitation, so intact cord resuscitation trials that are ongoing. But at this point, for the smallest babies, we can't recommend umbilical cord milking. And American Heart was somewhat silent on cord milking for older babies. In the NRP textbook, the upcoming 8th edition, we do offer cord milking as an option if delayed cord clamping is not considered viable. But when it comes to the smallest babies, we're still very concerned and can't recommend it.
Okay, so for babies who are more than 28 weeks of gestation, if DCC is not possible, we can do a cut UCM.
It is certainly a viable option. It is not clear, even from the Seidler meta-analysis, that there is a benefit. There appears to be, in clinical outcomes, there is a benefit in hematologic outcomes in the first 72 hours. So you will raise hemoglobin a bit, about 1 gram. You will raise hematocrit by about 3%. But it's not clear that there was any really clinically meaningful benefit. And looking at the animal data from Stuart Hooper's research group, it's not clear that cord milking actually achieves the goal that you're looking for, which is to support left ventricular output before the lungs are inflated. You may or may not force more blood into the lamb or the baby, but it's not clear you'll actually get the outcome that you're hoping for.
Yeah, I agree. Thanks, Gary. Thanks for the excellent answer. We'll move on to the next question. This is to Daniel. So this is regarding thermal management. So why does ERC suggest a temperature of more than 25 degrees Celsius in babies who are less than 28 weeks gestation?
Oh, yes, it is recommendation comes from, is not a evidence-based recommendation. It is based on another aspect that we have to say on the guidelines is that guidelines are very conservative. This is the first point, the baseline. Okay, they are based on the ILCOR evidence, but of the ILCOR document, but in general, it is very difficult to change a previous recommendation if you have not enough evidence to change it. Just to give an example, just to say you, for example, define inflation and so on, we will discuss it later. And so it was an old recommendation, 2015 version, and it is also a recommendation from the WHO. WHO recommend to have a higher temperature, higher than 25 degrees Celsius. And so we stay with the old recommendation, despite we know that it was not an evidence-based recommendation.
Okay, so this recommendation of more than 25 degrees Celsius is not based on evidence. It is mostly based on expert consensus. and to match with the WHO's recommendations.
Yeah.
Thank you, Daniel. The next question is also to you. Why does ERC specifically say skin-to-skin care in babies in healthy neonates for more than 32 weeks of gestation?
Yeah, also in this case, we have a very limited evidence on the skin-to-skin, on the impact of skin-to-skin immediately after birth. And our recommendation was based on, our suggestions, better to say, was based on this article. This is an observational article from the group in Praga. What they found was, if you go to the next slide, here you can see the relationship between the gestational age, the temperature, and NICU admission. And you can see here that a patient who receive skin-to-skin treatment compared to the traditional treatment, to the conventional treatment, had a lower temperature at 60 minutes of life, but this was more important for patients with a gestational age less than 32. There is the only randomized controlled trial supporting this. However, this year, last 2 weeks ago, this study has been published in, this is a revolutionary article, a very well conducted article, a large sample size. It included patients between 1 kilogram and 1.8 kilogram. And it is not immediate skin-to-skin contact. And so probably we are out of the delivery room or 1 hour, at least 1 hour after birth. And so we have to consider the result with probably with some limitation. But 1.3 hours after the delivery, the skin-to-skin contact, is better to say the kangaroo care started. And in this study, they compared two groups. One, look at the numbers, 160,000, 600,000, 600,000, so a very large number. And so one group started at 1.3 hours, and one group started at more or less more than 2 days, in the 30 days of life. And it is impressive, the median time of the kangaroo care. The mother maintained the kangaroo care for 20 hours, average 20 hours in both groups. And so, but the next slide, Abby, the primary outcome was the death between the 28 days. And you can see here that there was a significant reduction in mortality rate within 1 month of life in the group receiving immediate skin-to-skin contact. The reduction was about 25%. There was a reduction also in hypothermia. It is very impressive, in my opinion, the low rate of hypothermia. If you consider the birth weight of this patient, 1 kilogram to 1.8 kilograms. In one center in Mozambique, we had 60% of hypothermia in all population, and so this is very impressive as a result. And so, if you go to the next slide, I want to show you only this part of the slide. It depends on the center. The center in India was the most effective intervention in this center, and so while if you look at the other 3 centers, there was a signal in favor. Of course, the direction was in favor of this early skin-to-skin, but I don't know this center in India, maybe that you know them, and I think that we have to mirror the activity, because the result in this case was really very, very impressive. And so skin-to-skin, yes, probably, I don't know, there are many interventions. It is a bundle of intervention to improve, but skin-to-skin probably in some centers could be reasonable also in the delivery room when you have a good temperature of the delivery room.
Yeah, true. So maybe in low resource settings, the skin-to-skin care may work, but probably not for babies at 32 weeks of gestation. We are still struggling to do it for even term neonates, even in tertiary care NICUs here. So probably you should.
Sorry,
Yeah.
another important message for this study is that 20% of eligible patients were not included in the study due to concern of the clinicians, and so not all patients can receive kangaroo mother care or skin to skin. It depends on the clinical condition.
Gary, what is your take on this following skin to skin care for babies who are born at 32 weeks of gestation? Like how probably if the delivery room temperature is higher, then it might be safer. But like if it is a cold delivery room, then probably it may be riskier, isn't it?
Yeah, and that's clearly in the United States is not a practice that's very common. We still, there's no question, in North America, babies that are born that preterm are going to be medicalized. And so they are going to be cared for at a radiant warmer. They're likely going to be separated from their parents, from their mother. They are likely to find their way to an intensive care nursery fairly quickly. And we in North America are going to be thrilled if they get kangaroo care in the first couple days of life. So we have a ways to go. This kind of question and this kind of intervention, I think, would be very difficult to implement in many places in North America, and we still have, I think, a lot to learn. Kangaroo care, again, something that originally, Daniele, am I right? It really starts in Central America, South America, and in North America, it took us decades to learn this, and we still are.
Yeah, I agree. Thank you, Gary. We'll move on to the next question. So the basic step of neonatal resuscitation is positive pressure ventilation. But as we rightly pointed out, there is so much of difference between ERC and AHA regarding the PIP and the rate that we have to use for PPV. So what is the basis behind all these differences?
Abby, you have hit on something that we could spend an entire neonatal resuscitation conference on. Because you're absolutely right. Positive pressure ventilation or effective ventilation of the newborn, without question, is the most effective, most important step in neonatal resuscitation. However, we know so very little about it. And what we know about it is largely based in animal studies, basic physiology studies from largely from the UK in the late 60s, 1970s and 80s, from Tony Milner and Boone and Vyas. We have now, again, many more physiologic studies coming from Australia, from Stuart Hooper's research group, but we have virtually no information from randomized controlled trials. So almost everything that we recommend is based on expert opinion, from physiology or good guesses or observational studies. So it's not surprising at all that we have many differences. When we look at our rate guidelines, they were initially based on physiology studies from the 1970s and 1980s, and we tried to match what either we thought babies would do, or babies that were resuscitated with devices that we no longer use, and with measuring instruments that are now considered far out of date. And so ILCOR hasn't changed its guideline from 2005 to use 30 to 60 per minute. And American Heart originally based their guideline of 40 to 60 breaths per minute based on an estimate of what would lead to a normal minute ventilation. And it's based on expert opinion. The European Resuscitation Council this time, using 30 breaths per minute, was based partly on an observational study from Carrie Holt that was published in 2019 that wasn't referenced by either American Heart or ILCOR. The study wasn't published before American Heart completed their guidelines. And what it essentially showed was that there are many ways, as we'd say in the United States, there's many ways to skin a cat. And so there's a number of ways to get to the same outcome. And minute ventilation is rate times tidal volume. And so in Carrie Holt's study, where they looked at babies that were being resuscitated in Tanzania using Helping Babies Breathe guidelines and self-inflating bags with no PEEP valve, no oxygen, no airflow through, no additional airflow, they found that when measuring end tidal CO2, a large tidal volume, around 12 milliliters per kilo, which is larger than many of us would feel comfortable delivering, at a slow rate of 30 per minute led to the highest measured end tidal CO2. And again, if you're looking at end tidal CO2 and the greatest amount of end tidal CO2, if that's your measure, then slow rate, very high tidal volume may be most effective. We don't have any clinical outcomes from that study. So even if the study had been published by the time AHA wrote their guidelines, I'm not sure it would have made any change. And as Daniele said, once there's an established guideline, there's a kind of a grandfather rule in both ILCOR and American Heart, which is once you have a guideline, you need really good quality evidence to change it. And so I'm not sure that would have made much difference. Then when we look at peak inspiratory pressure, that's again largely based on physiologic studies from Dr. Vyas, Boone, and Milner in the UK in the 1970s and 80s. And the initial American Heart Guideline is based on the idea that Dr. Boone showed that a peak inspiratory pressure between 20 and 25 was sufficient to resuscitate and develop an FRC in most term newborns. And then we had additional data from Dr. Feiner in the United States that showed that when using a self-inflating bag, many resuscitators hit much higher peak pressures than they intended. And so American Heart was very concerned about giving overly large breaths. And so the guideline was essentially based on the idea of give the least amount of pressure initially that is likely to be successful, and then increase your pressure as needed. And so that's how American Heart has tried to be simplified by using 20 to 25. But we recognize that for some term babies, a peak pressure of 30 or even higher may be necessary. Personally, I believe that making a single pressure recommendation that needs to cover the possibility of face mask versus intubated, different size babies, C-section versus vaginal, whether your lung is full of fluid or not, if the baby is making any respiratory effort or not, finding a single number that works for every baby is terribly unlikely. And so in some respects, American Heart and NRP have tried to simplify a little bit, and it's possible we've oversimplified. I think here the concern from Therese Lamberska in 2015 that babies that were less than 25 weeks may not be doing well with current guidelines. This is hard to really come to very much conclusion. I think what they're showing in the two graphs here is that when they used a pressure of 25/6, here the two lines, the one on top is babies who did not have an IVH, and the graph line on the bottom is those who did have an IVH, and it shows their oxygen saturation and heart rate. And what this in an observational study tells you is that babies who do very poorly in the delivery room are more likely to have an IVH. What I'm concerned about in this observational study is that almost all of their babies failed to meet what we think is an important guideline, which is reaching 80% SAT in the graph on the left by 5 minutes of age. And I'm not sure why they struggled so much. And this may be because ventilation was ineffective. But if you go up from the 5 minute line like you are up to 80%, we feel that that's important, an important thing to guideline to meet. So if you take your cursor and go to the 5 minute on the x-axis and then go up to 80 on the y, that's where we hope preterm babies are, and we would expect you to increase FiO2 in order to get there. And none of their babies reached that guideline. And so I'm very concerned about what was happening in their unit and whether FiO2 was advanced as it's supposed to. Julie Oy, looking at 8 different randomized controlled trials, has suggested anyhow that reaching an 80% SAT by 5 minutes is an important goal. And so clearly things aren't going well, and but they're not going well for any of their patients, and I'm not quite sure what to make of it. And when we talk about face mask ventilation, it may be, if the glottis is closed, you may be providing lots of pressure and not much tidal volume. Then here, this is from Hege Ersdal's research group, which again is based in Tanzania, and this includes Carrie Holt's data from before. And this paper, this is again an observational study that shows what happens to babies when they are resuscitated following Helping Babies Breathe guidelines with a largely nurse midwives in the delivery room. And one of the things that they found was that when in their subjects, lots of babies got very large peak pressures, median around 37. Lots of their babies got very large tidal volumes, about 12 to 13 mils per kilo, and relatively short eye times of less than half a second. And so I'm not sure what to make of it. This shows what happened, and I'm not sure that it's the very best outcome. And I think it is more evidence that when you're using a self-inflating bag, it is, and they didn't have manometers. When you're using a self-inflating bag and basing your guideline on whether you see chest movement, you may give very large peak pressures. And we've seen that again in previous studies from Neil Feiner. I think from this data from Hega's study, the thing that's most important to look at is on the left side, the third graph down. This is very key, I think. When you start to get exhaled CO2, your baby is likely to improve, and you'll see that heart rate improves as CO2 is exchanged. The other thing that's important, I think, to notice is that they had a lot of leak at the mask. So across the board, they had almost 50% leak. And so one of the things that in the NRP textbook we've started to focus on is using a CO2 detector, which again we're well resourced. And so using a CO2 detector with face mask ventilation can be very helpful to guide you in your positive pressure ventilation. And I think in some ways from Hega's study, that's to me the most helpful data to show is, and this confirms what's been shown by others, is that exchanging CO2 at the mask is a good indicator that your baby is getting better. And if you don't see exhaled CO2, you need help with your technique. And the two-hand technique that Dr. V mentioned is one of those you should be considering.
Yeah, thank you, Gary. So we understand that it is very difficult to give a uniform guideline of what rate and what PIP we have to use.
Yeah.
Because of the difference in the size of the babies, starting from 500 grams to even 4.55 kgs. And to add on, there is not much evidence from RCPs. So that is the reason behind all these differences. Thank you. So we'll move on to the next question. This is to Daniel. So we all are very confused about this sustained inflation. We don't know whether it is helpful or not, but ERC recommends sustained inflation of shorter duration. So what is the evidence behind this?
European guideline does not support the sustained lung inflation as intended as higher than 5 seconds. And so this is important. It is based on the study published in JAMA 2019. What we maintain was a historical decision. We decided to maintain the 5 initial sustaining inflation because this recommendation was already present or presented in the last version, not only 2015 but since 2005. And the 5 inflation are common to not only for the neonatal resuscitation guidelines but also for pediatric resuscitation. 5 inflation are recommended because you want to be sure that you achieve effective positive pulse ventilation before starting the 30 seconds of ventilation. And 2-3 seconds are based on physiological study, as Gary discussed or said before, that have been published in 70, and so with different patients, yes, and with different devices for ventilation. And so this is why the recommendation remained at 5 initial. I don't know if sustained lung inflation, maybe, but is not sustained lung inflation intended as 20 seconds that has been also in our group not recommended or recommending against. You have to consider, for example, in the cohort, one of the cohort is the Ariane Pass. Ariane Pass conducted the study in Melbourne on the LAMS, where the sustained inflation was seemed to be very effective in the recruitment of the lung. And so is an important balance between what we believe but also what we have based on the meta-analysis on the last studies and on the human randomized control trial evidence against we suggest against sustained lung inflation, at least in the small patient.
Okay, so in Europe, you routinely follow this shorter sustained inflations of 2 to 3 seconds, is it?
Sorry?
Do you routinely follow this shorter sustained inflations for 2 to 3 seconds?
Yeah.
So for
Yeah.
all gestation, for which gestational age group?
Oh, but for all, we have not a difference for based on gestational age. All patients with gestational, independently from gestational age, are ventilated with such inflation time.
Okay, and you say that you're saying that it helps in better recruitment of the alveoli.
Yeah.
Okay, thank you, Daniel. So the next question is to Gary. So why AHA gave a strong recommendation to use ECG during chest compressions?
Yeah, and again, I think in partly this reflects again the North American implementation of ILCOR guidelines, where resources are generally not limited, and we have the ability to offer ECG monitoring when resuscitation becomes more complicated by the time we get to chest compressions. And so we clearly we all agree that during resuscitation of the newborn, heart rate is the primary indicator of response, and ultimately it determines which interventions you'll perform. And we know that quickly and accurately determining the baby's heart rate is important, because that's going to decide whether you're proceeding to chest compressions. And we have seen in a number of studies now, both in simulation of resuscitation and in live resuscitations, that clinical assessment by either trying to palpate the umbilical cord or listen with a stethoscope is not particularly reliable. And in simulations, half of errors made during neonatal simulation is as a result of inaccurate heart rate assessment. We know that palpation and auscultation lead to frequent errors. And even in communication, when one member of the team has to communicate the heart rate to the whole team, about 25% of the time, there's an error in that communication. And so we believe that data is sufficient to suggest that ECG is the most rapid and accurate method. And several studies, including this one from Mizumoto back in 2012, showed that the time to get a heart rate is much quicker by ECG compared to pulse oximetry. And it was a median of 38 seconds versus almost 2 minutes. And during those first 2 minutes, you're making critical decisions about which interventions you're going to perform. And we know that pulse oximetry may not, in babies who are most depressed, pulse oximetry is not going to pick up. And so we have evidence that ECG identifies both the start and end of bradycardia faster than pulse oximetry does. It's more accurate than pulse ox during bradycardia, even though we recognize there is a small risk of pulseless electrical activity. At least American Heart Association, our assessment was that it is unlikely that you will have fast rate PEA that is going to change the decision you made. And so certainly in North America, if you've gotten to the point where ventilation was not working, we recommend that you need an accurate assessment of heart rate, and ECG is the most accurate. In addition, while using ECG, if you are doing chest compressions, we have some evidence that it will decrease the amount of time that you are stopping compressions. And every time you stop compressions, you lose coronary artery perfusion pressure, and it takes half a minute to get that back. And so if using an ECG can tell you what the heart rate is doing faster, then we believe that it is likely to be more effective. And so for North America, we made a strong recommendation that if the baby's not responding to ventilation, that ECG is strongly recommended. But we recognize this may not be a guideline that can be implemented in all settings.
Yeah, this 38 seconds versus 122 seconds is glaringly different. We do agree. But as we already discussed, like we are still struggling for pulse oximeter.
Right.
So ECG and ETCO2 are all very far-fetched for us.
Yeah, and we feel, again, in the United States, we feel that neonates in some ways in hospitals have been discriminated against in hospitals for decades. and that nobody in the United States would argue that if you were performing CPR in a hospital for an adult, that they should have an ECG on and they should have a defibrillator. And so hospitals purchased all kinds of equipment for adults and expected that for newborns in the United States that we felt the pulse at the cord. And we felt that unless American Heart Association took a stand and said you should do this, that we would continue to allow hospitals in the United States to provide less support for newborns than they would for adults. And in North America, that's not acceptable. And so we recognize that this is a regional guideline that may not be able to be implemented internationally, but we felt it was important for us to take a stand for newborns in the United States.
Yeah, rightly said. Like,
Abby, may I do a comment here on the electrocardiogram? No, we in Europe we don't do a strong recommendation should be put the electrocardiogram, but of course we consider electrocardiogram, and so is in general it is written, and so it is recommended. I would like to say you that, for example, in the algorithm for the first time we included consider intubation when you start chest compression. And we receive many concerns from one council in Europe, because just to give you a different point of view of the council in Europe, because they said there is a letter that has been published, or it will be published in Resuscitation during this day, because they say, okay, if you write consider station, it is a recommendation. People have to intubate this patient. And you can have medical legal consequences if you don't do it. And if you think to the whole hospital in Europe, the level, as Gary said, for US is completely different. And so for this reason, strong recommendation on electrocardiogram is better to suggest or to say you can use it instead of you should have to use it is a compromise. Yeah. Based on the different consideration. And so just to give you an example how algorithm or guidelines was born.
Yeah, I agree. I have a small question to Gary. Have you seen pulseless electrical activity in neonates during resuscitation?
We have seen pulseless electrical activity at very low heart rates and not very commonly. One of my colleagues and a tremendous neonatal resuscitation researcher in Canada, George Schmolzer, they seem to find a lot of PEA in Canada that is at a very high rate, at a rate greater than 60 beats per minute, which would change your decision. In the United States, we just haven't been seeing that. And we see PEA at a rate of 30, maybe 20 or 30, but that wouldn't change your approach. Even if you have PEA at a rate of 20, 30, or 40, you're still performing chest compressions. And so we have not really been seeing trouble with PEA. I think one of the fascinating options that we are considering, and in the NRP textbook for the first time, we'll offer it in the 8th edition that was just published this month, is to use, again, in settings that have it, a Doppler ultrasound. So the handheld Doppler ultrasound that the obstetrician uses to measure fetal heart tones, you can place that very same device on the baby's chest. And Dr. Trevisanuto has published on this, and colleagues have published on in Italy. And the beauty of that is that it actually measures flow. And so it can distinguish between PEA and actual blood flow. And so I think this is fascinating. There has not yet been a randomized trial looking at it, but this is a device that is very common in delivery rooms in North America, very common at least in many countries in South America. And this is potentially a very useful device to separate PEA. But no, in answer to your question, I don't think in the US we're seeing fast rate PEA that Dr. Schmolzer has reported from Canada.
Yeah, thank you, Gary. The next question is to Gary again. So is there any scientific basis for designing the resuscitation algorithms?
Yes, there is some scientific basis. And again, algorithms, one of the things you have to decide when you're creating an algorithm or a decision tree, what's the purpose of it? Is it to be hanging on the wall in the delivery room to act as a guide or reminder for people who are actively involved in resuscitation? Or is it a learning tool to keep in your pocket and remind you before you go into the delivery room? Or is it for a textbook so that as you're reading the textbook, you have structure to read? And one of the problems when we create algorithms is we don't always think exactly what's the purpose of it. And so there are guidelines written for algorithms in high-risk industries, including in air flight and in nuclear power plants and how to handle emergencies. And there are some published guidelines. We have Helen Liley from Australia has compared a number of our algorithms using the CMAT tool, which is a checklist score. And frankly, none of our algorithms scored all that well. And I think one of the questions we have is how much should you put on the chart? If it's going to be used in the delivery room while you're actively working, it can't be very busy. It has to be clear. It has to have few words. The words have to be big enough to read, and you can't be looking all around trying to figure out. It's got to be step by step and we think very sparse. And so at American Heart and NRP, we have moved toward trying to limit what we put on the algorithm. However, we have constant discussions about, shouldn't we add this? Shouldn't we put this on it? And it's very difficult. And truthfully, we probably need more than one algorithm. We probably need a very basic algorithm for 80% of babies, and then a much more complex one like they do for the adults. For adults and children, they have, different algorithms. We have tried to stay with one, but it may be getting to the point that we need to use more than one algorithm. And we'll have to see. But it's very difficult, and I know Daniele and the ERC group struggled with the exact same questions.
Yeah, right. Yeah, you're right. So just for the listeners, there are specific guidelines on what color, what shape, and all to use in all these algorithms. And I think the ERC has tried to follow most of the guidelines suggested by these.
And I saw, one of the people put up in chat, there are some questions about using apps, whether you can use an app to help guide you. And that's fascinating. And given that, smartphones are now available even in many settings around the world, developing a smartphone app to guide you has been looked at by a couple of groups, and it's a very promising approach.
Yeah. Thank you, Gary and Daniel. So to conclude, the guidelines of AHA and ERC are predominantly based on ILCOR COSTAR. However, for some elements of neonatal resuscitation, the recommendations by these two councils vary significantly. The differences are largely related to the evidence gathering process and paucity of evidence for certain practices. Over to Veer. Veer will take over the questions from the audience.
Thanks, Abhi, Gary and Daniel. So we have around 15 questions here. So Dr. Subramaniam is asking, when baby is improving with bag and mask ventilation and desaturating after stopping bag and mask ventilation, how long we can continue? Basically what he's asking is how long we can perform positive pressure ventilation with bag and mask ventilation, and when should we intubate? I think, Gary, the NRP does say something, right, regarding this?
We don't have a specific statement about when you should, and that really varies. And I think it varies based on the baby and exactly what your, what situation you're in. It's certainly like in my own delivery room setting, if for preterm babies, because we're trying so hard to support them on CPAP, we will continue face mask ventilation for a while. But so if a baby is improving and then you stop, should you restart versus intubating? In my own delivery room, we advise our trainees that if by between 6 and 8 minutes of age, the baby is not breathing, that they should intubate, but there's wide variation, and American Heart and NRP don't have a specific guideline or statement. So it depends a little bit on your assessment of the baby. And if there's something that's likely to resolve, like if they were exposed to general anesthesia and all you have to do is blow off the inhalational anesthetic, then you may wait even 10 minutes. And if they're responding, if they're not responding to positive pressure ventilation from the mask, then you need to move ahead to intubation quickly.
Okay. Thank you, Gary. This is a question by an anonymous attendee. What is the upper limit of time for delayed cord clamping in ILCOR, AHA, and in ERC? What is the upper limit? They say at least 30 seconds, at least a minute. Is there an upper limit for DCC?
I'm going to hand that to Daniele.
No, there is not. We didn't recommend a upper limit. We know that after 3 minutes is the blood has already passed from the placenta to the baby, and so if a baby is well, we can reasonably wait for 3 minutes, and so the recommendation is only the lower limit. If in a patient or preterm, full-term newborn who does not, who don't need the resuscitation, it is recommended to wait at least 1 minute. And so, yes, I think that after 3 minutes is reasonable to stop, to clamp the umbilical cord.
And if you're compelled by the animal data on physiologic guidelines for cord clamping, what's really most important is just to wait until the baby has established spontaneous respiratory effort. And it's very possible that once they've taken their breath and supported that it may be irrelevant how long you leave the cord unclamped at that point, but keeping it clamped, keeping it open until you've actually filled their lungs, that may turn out to be more important than any, time.
Yeah.
Okay. So there are lots of questions from our anonymous friend, and quite relevant questions. So he or she is asking another question. There was a recent network meta-analysis published by Boni Jasani in JAMA Pediatrics on umbilical cord management. And it had shown that in babies less than 28 weeks, no additional risk of intraventricular hemorrhage with UCM. So the author presented the same network meta-analysis last week in a journal club, and I had indicated the differences between the ILCOR meta-analysis and his network meta-analysis. If you see the certainty of evidence rated by ILCOR, it is low certainty of evidence to say that there is no difference. Whereas if you see Boni's article, they are given a moderate certainty of evidence. Basically, the difference was they have not downgraded for blinding of the outcome assessment of IVH. Whereas the ILCOR says you have to blind. Even IVH is something that is subjective. For you, IVH with ventricular dilation might be different. For me, I might say there is no ventricular dilation. So there are lots of issues related to that, but as rightly pointed out by Gary, individual patient data meta-analysis and the largest RCT showing really significant differences in the rates of IVH. And as AHA rightly suggests against IVH, I still feel that we should not go by single studies. Unless you have a high certainty of evidence, we should be cautious in babies at less than 28 or 29 weeks. So that was just a commentary, Gary, because this was a question that I asked the author myself. So please summarize again about skin-to-skin recommendations. Both AHA and European doesn't recommend it. That is a question again. Both AHA and European doesn't recommend it.
From American Heart Association, skin to skin is recommend. So we recommend skin to skin care in the delivery room for well newborns. There's no statement on skin to skin care in American Heart for babies that required resuscitation. For well newborns, we recommend immediate skin to skin care. And in the NRP textbook, similarly, if the baby is well, we recommend immediate skin to skin care. We don't have a recommendation. It's not that we recommend against it. We don't have a recommendation on what to do for babies that are not well or require resuscitation. And so it's not that we don't recommend it. We just don't have a recommendation.
the European guideline does not recommend. They suggest the possibility to use skin to skin in baby higher than 32 weeks. And so it depends on your delivery room, the temperature, environmental temperature, the request of the parental desire. And so there are many aspects that you have to consider. And so just to say that it is a thing that you can do, but it's not a strong recommendation. That's what we say.
Thank you, Daniel. So this was a question that was asked to Daniel when he presented the first thing on ill-course neonatal resuscitation. So he was bombarded with the changes in the coming NRP. I think Gary would be able to answer it better because he is the editor-in-chief of the book. Please discuss about any change in 4 questions asked before delivery. Is cord management a question to be asked? Again,
yes. So, yep. So, we classically had 4 questions in the in the NRP approach. When you went to the delivery room, you asked the obstetric provider 4 questions. And we just for educational efficiency, we did not want to increase the number of questions beyond 4. And ultimately, we decided the question, how many babies are you expecting, was part of the broader question, are there other risk factors? And we wanted to include a plan for umbilical cord management in those 4 questions to make sure it was established before birth. And so in the 8th edition, we've removed the question, how many babies are there? Believing again that multiples will be answered as other risk factors. And we've added the question, what is our umbilical cord management plan? And so, yes, umbilical cord management is now one of the 4 questions. And in no way did we want to de-emphasize the importance of knowing if you're getting twins or triplets. We just thought that would be answered already.
For our point of view, we decide to include in the algorithm the delayed cord clamping because we think that is important, not of course in patients that who need resuscitation, but just to as the American algorithm say, stay with the mother. We use perform delayed cord clamping. One of the most important difference, I think, is that the question about full-term newborns, a gestational age. Is it a reasonable question? For us, it's not a reasonable question because if you have late preterm infants that is stable, you can consider to stay with the mother, to do the delayed cord clamping and so on. And so for us, it's not in a part of the late preterm infant. 6% of late preterm infant, or 6 to 10% need resuscitation at birth, and so the most part of them can do the transition without a stronger support or resuscitation support. And so we decide to avoid this initial question. Instead, we stressed the heart rate, if you see, because the American algorithm check the heart rate later in the algorithm, not immediately at birth. And so this, I think, is the most important difference between the 2 algorithms at the beginning of the algorithm.
Thank you, Daniel. There are lots of questions. I mean, do we have time? We are already 1.5 hours into the talk. Our anonymous attendee is most likely a very experienced neonatologist because the questions that have been asked by him or her are quite relevant, and I don't think we have any answers. So one relevant question that is asked is, please let us know what to do when there is spontaneous but irregular respiratory efforts on bag and mask ventilation. How frequently to check for respiratory effort and what's the endpoint? I mean, how to wean off positive pressure ventilation. That's what I think he means.
I want to come back to the previous question. How long do you ventilate the patient? And I think that the algorithm is a guide, but we have to think to the pathophysiological situation of the baby. That is the most important thing that we have to consider when we are there, and when we do individualize the therapy or the support. And so that is very important. When to intubate a patient, I think that if a patient is hypoxic, okay, you can consider, you can look at the saturation, livers, but in general, if you have the saturation but a reasonable good breathing, you can consider, I don't know, pulmonary hypertension, just to give if you have not a malformation, congenital cardiac malformation. And so at that point, probably you can consider, as Gary said, the CPAP, and you can consider, for example, the level of FiO2. If you have one patient with 80% or 0.8 of FiO2 and with respiratory failure, okay, at that point, you have to go with endotracheal intubation. But just to, I think that the message is look what your patient wants. That is, in my opinion, the right approach, because there is not a magic answer for all the patient. And so I think that is, if you have a spontaneous breathing with irregular respiratory effort, that means granting, maybe in that case, the most effective intervention is administer CPAP at 6-7 centimeter water. Just to give an example, if you have not an improvement, you can move to other intervention.
So basically, these guidelines are all just a overall guidance they will give you. But based on the individual scenario, we might have to take our own decisions, what is most appropriate for the patient. One last question from Suraj. I am asking this to Daniel because I think his ILCOR meta-analysis was published by him on this subject. Please discuss the recommendation for intubation and removal of meconium plug if a baby presumably born through meconium-stained amniotic fluid is not improving with positive pressure ventilation, not the routine suctioning. I mean, you have started PPV, but you might think that there is a meconium obstructing the airway. Do you? I think NRP does say you consider intubation. If I'm not wrong.
Yeah. You consider to remove the meconium from the trachea, and so the changes. The change in the recommendation on meconium situation is very challenging for the clinician, because historically we intubated this patient, we did the toilet of the trachea and so on. But evidence is against. In particular, there are 4 randomized controlled trials from India that show clearly that intubation, elective intubation, is not effective in terms of meconium aspiration, incidence of meconium aspiration syndrome, in terms of mortality, and in terms of important outcome. But if your patient is not, if your chest is not moving, please consider an obstruction. Also, not only with the meconium, but also with clear liquid. You have to consider the airway. And in that case, you have to intubate the patient and to do the suctioning by using the endotracheal tube, the device, the meconium device that is not available in the delivery room, but that is again, your patient say you what he has. Why the chest movements are not coming on? Maybe that was obstruction, maybe that you have a pneumothorax, for example. And so, yes. However, if you have initial ventilation and you have not an improvement of the patient, in that case, you have to intubate to clean the trachea. And so, and after you reintubate the patient, we organize a nice paper with we published with Gary on the time of intubation, in the mannequin study, and the time is not so long compared with between the two techniques, but however, routine intubation at this point is not recommended. So we suggest against routine intubation in these cases.
Yeah, absolutely agree with Daniele. It's the statement about routine intubation is not recommended, but if you have meconium obstructing the airway or blood or vernix or anything else, it's not just meconium. you may need to intubate the airway and suction. And we've been concerned that in North America, people have misunderstood that we're saying no baby with meconium ever needs to be intubated and have their airway cleared. That's not true. It's just routine intubation is not recommended. But you still need to have providers in the delivery room who can intubate. You still need to have the equipment, and you may need to intubate and clear the airway. It's just intubate and clear the airway when it becomes necessary, not as a routine elective procedure.
Thank you, Daniel and Gary. Just a question: when is the book going to be out? June was what you told us, I think.
Yep. So the 8th edition NRP textbook should be shipping right now to people who had pre-orders. And I didn't look on Amazon or Barnes and Noble this morning, but it should be available now. It's the publication date was June 1st, and I believe pre-orders are shipping right now. But I don't have my own copy yet. I have to call AAP.
This morning, Gary, I received a phone call from a colleague from Sardinia, and she told me, I have read the 8th edition of guidelines of the manual. Oh my God! Also, it has been published, so I can confirm that is around the world.
Sounds good. All right. Well, and the translated versions are on their way. So Spanish, French, Italian, Portuguese, the translated versions will be coming within the next 12 months.
Great. I'll just finish it up with one last question. I missed it from Mr. Manish Mittal. Can't we design an audio algorithm based on artificial intelligence?
Yeah, definitely. And we did a little bit of work several years ago with an app for an app that would guide you through the resuscitation algorithm. George Smoltzer has done a little bit of work. Of course, the challenging thing is when you make these artificial intelligence supported apps, you have to have some. They don't make any money. And it's very difficult to get software developers to be interested in making these apps and then keeping them updated, and then also making new versions as software is changing to make sure that it's up to date with the most recent operating systems. And they never make any money. And so you have to have somebody who's interested in financially supporting it, and then people who are committed to keeping it up to date. And that's a challenge. So I do think that the option to have an audio algorithm with artificial intelligence is brilliant. We should have it. We have the technology, and it's more about the business side of it that's very difficult.
I think that this kind of tools are very important for educational purposes. That is most important probably than in the real life, because in the real life we have not time, and so probably the how to say the video registration could be helpful in this condition. You are in a peripheral hospital. You need the stabilization of the patient. You go with the expert in the level 3 hospital that can guide you. Maybe not immediately, but in the postnatal resuscitation phase could be reasonable. And so, but I think that the values of these tools is in the educational objective.
Yeah, there is a neonatologist at University of Minnesota in the United States who has done a lot of work on telehealth resuscitation. So having a neonatologist at a regional center guiding teams at local hospitals by telehealth consult, and that appeared to be very, very helpful. But creating those networks and supporting those networks again takes a real commitment from a health system.
Okay. I think that's it. We were not able to answer many questions because we already, I think, almost we'll reach 2 hours now. So I think we can conclude. Any concluding statements from you, Gary, and Daniel and Abhi?
I think, again, there's so many questions, so much evidence that we still need. We really encourage people who are interested in resuscitation to get involved with reading the co-stars and posting public comments. If you have a particular interest in resuscitation, get involved with your counsel. Potentially become involved with as a content expert with the ILCOR NLS. I was impressed with the number of really good questions that have been asked, and then always impressed with how little evidence we have to answer so many of them. So I hope we can do better for you in the next cycle.
Thank you, Gary. Daniel, do you want to say something before we end?
Thanks for inviting me, and I agree with Gary. You are very welcome in the group, and I would like to organize some randomized control trial to increase the quality of evidence or the quality of what we are doing now. I think that you have large number. We are very high level of also of assistance, but also you are living in a middle income country, and so I think that some results that are coming from your country are different
Yes.
from other country or other settings, and so I think that it is another opportunity for us to learn from your experience for the result of your study. And so also this aspect I think that has to be cared for by your group, and that is a high level group, as the answer in the chat showed. Thanks again.
Yeah. And Abby, Vera, thank you for organizing this and also for inviting me.
Thank you, Gary. I just want to summarize this umbilical cord management, as there has been so many questions on this. So if the delayed cord clamping is feasible, there is no confusion at all. We have to go in for DCC. So only in babies who do not cry at birth and we cannot do delayed cord clamping, there is a confusion. So if the baby is more than 28 weeks gestation, then we can do a cut umbilical cord milking. That is umbilical cord milking after cutting the umbilical cord and shifting the baby to the radiant warmer. For this also, there are definite guidelines on at what rate you have to milk and at what centimeter you have to milk and all that. Probably we'll have to go through some of the protocols followed in RCTs and follow if we want. For babies who are born at less than 28 weeks of gestation, as of now, we don't have an answer. So UCM may be riskier, so it is better to avoid it. Am I right, Gary?
I think that pretty well summarizes it. And I think we're still a little bit unclear about the difference between intact cord milking and cut cord milking. I think, again, and I'm clearly not an expert on the cord management questions. It's so complicated, all of the multiple comparisons. And so at this point, I'm unsure how to answer the question of the difference between cut and intact cord milking. In my own practice, if you're over 28 weeks and delayed cord clamping is not an option, then we suggest consider cord milking. And at least in my own setting, we use intact cord milking. And then we recommend delayed cord clamping for all with uncertainty about what to do if they need resuscitation. So yes, Abby, I agree with you. I'm just not sure about the difference between cut and intact cord milking.
Yeah, I agree. But if we can do an intact umbilical cord milking, we can very well do DCC,
Yeah.
no?
So for DCC, then you're waiting a minute. And if you can't wait a minute because you feel the baby needs resuscitation, you can do 3 to 4 intact cord milkings, clamp the cord and move the baby. And so if you feel that you can't wait that full minute and you want to give some placental transfusion, intact cord milking may be an option.
Okay, I agree.
Okay, then shall we conclude? I'm tired.
Yes, thank you so much.
Thank you, Gary. Thank you, Daniel. Thank you, Abhi. Thanks everyone for joining.
Thank you.
Thank you all.
Bye-bye.